beautiful introduction to my friend Jamil, because Jamil actually was in the Unite for Her program. That's how I met Jamil.
I
And
still am.
you still are. You still are. I know. What am I saying? For our women living with metastatic disease, we treat them
Yeah.
for life. So, but Jamil started with us too. When you first started, you also did our fashion show 2 years
Yeah.
ago.
Mm-hmm.
And that was so sweet with your boys. And we just got to know you in such a personal way. And Jamil, you give back so much. It's not just Unite for Her that you are an advocate for. And if you get a chance to get on Jamil's website, and it is Chrysalis, the Chrysalis Initiative, you're going to see a bio that is so impressive. Not only serving her own foundation and building this, but she also serves on MetaViver. She serves on Living Beyond Breast Cancer. She works with Susan G. Komen. And then her own initiative, I can see a lot of her efforts now starting to pour into your initiatives, are all around helping to bridge that social disparity and health inequities in the Black community with breast cancer. And not only for the patient, but
Yeah.
for the providers, for the
Yes.
healthcare workers, there's so many different levels to this initiative, Jamil, that I was so impressed. And I wanted you to come out and speak and just share everything you've been doing, because we're just so honored to see such an amazing story come out of your diagnosis,
Wow.
and as a survivor, I totally get it, right, Jamil? Like, I totally get it. And it's like, when you see a gap, you want to bridge it,
Yep.
And my gap was the integrative therapies, your gap
Mm-hmm.
was health inequities. And I'm just so proud and honored. So Jamil, I am going to turn it over to you.
Well, no, exactly how you said. I appreciate you and Unite for Her so much. You are a big part of my family, you know. I am married to a two-time cancer survivor, colon and kidney. And so when I was diagnosed at 39, didn't really have any strong history to speak of, really was not on my radar. I could not even imagine, getting that diagnosis and, thinking that my kids would have two parents with cancer. So it just wasn't even on my radar at all. But really just got the diagnosis, no real signs or symptoms except for a lingering cough. And then, just me following up and going back to the doctor saying, I know something's going on here, and getting that chest scan. And I also asked for an ultrasound and showing that I had lesions all over my body. So no, felt fine, typical mom, going to work and everything else. And, metastatic de novo. So stage 4 from the start. And I knew from there I had a lot to learn. I had no idea breast cancer was so complicated, and luckily I learned about Unite for Her 3 months after I was diagnosed. So I was well into my treatment. I had to get chemotherapy right away. But again, I saw what my husband went through. It took him a year to get his disability approved after his cancer diagnosis. And everyone was on my benefits. So I knew I had to keep working. I had to sustain myself and take care of myself. And I learned about Unite for Her, and the support that Unite for Her gave me and continues to give me sustained me in order to keep me going, because chemotherapy, the treatments that we go through living with metastatic breast cancer are brutal. Even now, even though I did a year of chemotherapy, I reached no evidence of disease, thank goodness. And I really do think it's because I was able to stay on there for the full time until all of those tumors shrunk and disappeared. But now, even with the aromatase inhibitor and the CDK4/6 inhibitor, they have side effects too. And, it's really great that Unite for Her, the benefits in the wellness program, doesn't stop if you're metastatic. And it has really sustained me and provided so much support for my family. And my kids, they do eat the sun basket. So instilling that good, healthy eating. So we really appreciate that.
I love that. They probably look for that box to come in, right?
They're like, more vegetables, Mom. But really, getting involved as an advocate early on, joined the board of Living Beyond Breast Cancer, joined the board of MetaViver, serving as board president, working with Susan G. Komen and being on a couple of advisory committees there, I kept seeing, I was so shocked to learn that Black women are dying from breast cancer at a 40% higher rate than white women. And I said, well, what is this about? What can we do? What's going on? And I just kept on hearing over and over again that it was due to social determinants of health, or that there was distrust and low participation of Black women in clinical trials, and that it's due to poverty and access to care and lack of insurance. However, when I started doing more and more of my research, I found that actually it's more so the systemic bias and racism in the care setting that is the biggest contributor to Black women not being able to get that standard quality of care. And, you know, as I started, I had developed a curriculum for myself just to keep myself on track on how to make sure that I got the best care. And I started coaching other women to receive that information, just to be knowledgeable about what is that quality standard of care and how to make sure that you get it, and how to see those signs of bias and racism and how to address it. And then I shared the pilot in the program with a few organizations. And each time I found that with that coaching, the outcomes of the Black women mirrored the outcomes of the white women. So meaning it's eliminating the disparities. And but all of those projects were one and done. And so I thought, well, the need is so great, I could do this every day. And so I launched the Chrysalis Initiative, and this is exactly what we're doing. So we're taking all of our participants, primarily focused and born out of the need for women of color and patients of color. But we provide support and one-on-one coaching for all races, all stages, all ages, no matter where they are as far as in their breast cancer continuum of care. But we're there to, you know, go through everything. So for them to understand what is that standard quality of care, all those aspects that are important, not just in the treatment and the testing, but also that psychosocial and all those additional support benefits that you need in order to make sure that you're managing your breast cancer care the best that you can, and you can sustain yourself and stay adhering to your treatment as best as possible. And as we're reinforcing and providing support to people with breast cancer, we're also ensuring that, you know, the cancer centers have to get their act together. So clinical trial sites and also cancer centers, we developed a curriculum that shows them how they can identify those blind spots within their breast cancer program and care, to ensure that they can, you know, deal with the implicit and explicit bias, the racism that kind of, you know, hides in different areas, and how can they assess that and get some visibility and accountability in place. And so we come in, we do an equity assessment, we show them where all those blind spots are, and then we work with them to replicate the Chrysalis model, and then work with them to have a more equitable breast cancer care program. And then on top of that, we have the student program, which trains middle school students and high school students, and now medical school, on the equity curriculum. And then we have our patient advocacy program. So now that patients, you know, they become more confident and ready to advocate for themselves, we connect them with other advocacy opportunities like at Mediviver and Living Beyond Breast Cancer and Tiger Lily Foundation. But we also connect them to opportunities with Susan G. Komen and the Department of Defense Breast Cancer Research Program, doing grant reviews, working on clinical trials, because we need more Black and Brown patients living with breast cancer and having that experience to share our unique challenges, so that these treatments that are being developed are inclusive to meet our needs as well. And that's what we're doing. So it's really exciting because we just launched in 2020, late 2020, as a formal 501c3 nonprofit. And we're already working with 25 cancer centers. We're close to serving and providing support to close to 1,000 women. And each single cancer center nationwide, we're finding that the disparities are being eliminated. But what's so disheartening is most of the cancer centers that are pulling us in are the ones that are really focused on addressing disparities and equity, right? So meaning this is something that they're prioritizing, and we're still finding pockets and blind spots of systemic bias and racism in the care setting. And every single time, it's almost as if it's like a diamond with a flaw. It's almost, there's a chip in the paint. Every single time we have a new enrollee, we find that there was something missed, something muddled as part of their standard of care. So good examples, is that Black women, we tend to not get the full diagnostic workup of testing, that we should receive when we are first diagnosed with breast cancer, or even having access to those innovative treatments or clinical trials, or being provided that resource and support for financial toxicity or palliative care to deal with symptom burden and manage side effects and continue on treatment for a long time. Typically, Black women are not connected to those resources at the cancer center. And so we are able to be that bridge to connect them with those resources and make sure that they can have the best quality care possible. And that also certain things as far as just genomic testing or treatment that's selected or additional scans that need to happen, or just making sure that they're getting at least the standard quality care. But every single time there seems to be something that's missed, and we're able to put a spotlight on that for them to say, hey, no, actually, let's ask about this too. Let's make sure that you get the care that you deserve.
I'm actually going to jump in here real quick because it's so impressive and so powerful, Jamil. And when you're saying you're treating 1,000 women, you're coaching those women. Is that correct?
Right.
You're
So
coaching
part of
those
each
women.
cancer center,
No.
we can receive individual referrals. Anybody can sign up for the program. But at the same time, we wanted to demonstrate the efficacy of the program. So each cancer center, we have a small pilot. Typically, it ranges in between 35 to 200 women, depending on the center. And then we're comparing those outcomes with the coaching that they receive with the general breast cancer population of that cancer center. At the same time, they're receiving the equity assessment, and we're able to show them where those blind spots are as part of their breast cancer program. Because a lot of times, in this labyrinth of, big cancer centers, you can get kind of lost in the maze of what's going on. And they believe that, we definitely, provide that bridge, or we're connecting people to resources. And when we do our focus groups, we find, actually not so much. And let's, improve in this area so that, you don't have to be the assertive one or that assertive fish swimming to the top of the ocean, raising your hand all the time, but making sure that you're meeting the needs of all of those patients, especially the ones with additional challenges, to make sure that they can receive the full benefit of that breast cancer program.
That's terrific, Jamil. I just, my wheels are spinning as I'm listening to you because, I truly know that even with us with recruiting, we know we are missing our Black women. We know it, and we're looking for them and finding ways. And we realize that we're not always going to get it from the cancer center. So now we're leaning in to go to other organizations, community leaders, people that are right embedded in Philadelphia in that community to get our word out. And it's usually they deal with all health issues, but we're learning that we can't just rely on one like funnel in order to do the recruiting. And I know I've even asked you, I'm like, Jamil, send women our way, which you do. So that way, because if you end up coaching them, can you imagine them getting this integrative care program? That's a gap that the hospitals are missing anyway. But now we're able to get that gap bridged even better for our women of color. So
exactly, especially now that you guys are nationwide.
Oh, it's
so we definitely do.
Yeah, it's so good. Jamil, do you want me to open it up for any questions?
Sure.
Yeah.
Absolutely.
All right. So, ladies, we have a nice, small, intimate group. So, I feel like, you can definitely unmute yourself and ask any questions that you like of Jamil. Usually we put them in the chat, but this is nice, So, if you want to keep Jamil on speaker view, and I'll keep the gallery view, and then I can see where the questions are coming from as well, just so I can point who's asking Jamil.
Got it.
Yeah.
Hi,
I have a
Shamika.
question. Oh,
Oh,
I'm sorry.
No, go ahead, Shamika. You go ahead.
Um, I have a question since you mentioned like the scans that women don't get sometimes. After I completed chemo in 2018, I remember asking my doctor, I'm like, so now what? Like we're operating as if I'm cancer free? And he said, yes, like you need to believe it, you are. And then by 2020, I'm being diagnosed with metastatic breast cancer. And people I talk to always say, well, did you get a scan? Like after, like, how do they really confirm that you're cancer free? And I'm like,
Right.
no, I had chemo and radiation. That was it. So like, is that
Yeah.
common?
I find that's really common. And we always say that there has to be some type of maintenance afterwards, meaning, get it on the schedule. If you're an early stager, you might be in that survivorship phase, but there should be, at least, right after radiation and you've gone through all of your treatment, you get that follow-up scan 6 months after that.
Right.
And then if that's clear and it's confirmed that that's clear, then the next one is 1 year after that each time,
Right.
and I mean, it really is necessary because I kind of feel that there isn't too much of a difference between early stage and metastatic. Yes, the needs are different. The treatment is a little bit more intense on the earlier stage side sometimes, but really there is that chance of an early stage or becoming metastatic, at least at 35% that we know of, even though we know that the data is skewed. And so really it's just a matter of testing, meaning if you've been diagnosed at early stage, it could be very well that they just don't have the screening capabilities in order to identify that it has had any type of spread, and so that really breast cancer, you have to, even as an early stager, you're going to be on some type of maintenance and monitoring after that in order to jump on it and address it if it is metastatic. And so I think we learn a lot more now about just how often you need to monitor it, even with the maintenance and things like that. For a long time, we were operating under the idea that we just have to find it early and nuke it early and cut it out early. But now we know that actually breast cancer, it can come back, 5, 10, 15, 20 years later. And so it's an ongoing thing that and cancer mutates, it adapts. And so we always have to be monitoring and having like a maintenance plan after that initial treatment happens.
Right. Okay.
Can you tell me, I know the statistics, I'm 17 years out and you're right. Like we always will look over our shoulders, right? And the statistics are 35% of early stagers turn to a metastatic diagnosis. Is that within the first 5 years? I felt like I heard, is that statistic associated with a certain?
No, it's just in general.
It's just in general.
Yeah.
So there isn't like, once you get past 5 years, then the statistic changes.
Right. Nope. Actually, they consider survival. If you look at the breast cancer statistics, that survival is considered to be past that 5-year mark. But just think about all the metastatic people that are diagnosed beyond that 5-year mark. And so I know that serving as board president of Medivivor, that's one of the things that we were really strongly advocating for, so that we can have actual true data. And so working with SEER, that is pretty much the authority on all of, that dictates the appropriations and resources and how we're doing with cancer. Good example is they only track metastatic breast cancer, so stage 4, if it's stage 4 from the beginning. So there are discrepancies sometimes where if someone is diagnosed with stage 2 breast cancer, and then it metastasizes or comes back later, and then it ends up where they perish because it's breast cancer in the lung. It's breast cancer that has spread to the lung area. A lot of times, certain states and agencies will categorize that death as a lung cancer death. And it's that's not a lung cancer death. That is breast
Right.
cancer that has spread to the lung. And we really have to have true data and be honest about that so we know how deep the problem is. So even with skewed data, we know that we have 42,000 people dying from metastatic breast cancer every year. That's plain every day. And so we have to be focused on developing more and more treatments available in order to make metastatic breast cancer a chronic illness, instead of this mentality that if we just find it early and cut it out early and nuke it early, that's the ticket. No, the ticket is treating the metastatic breast cancer.
Jamil, this is Karen. We had a conversation when we did the walk, about a month or so ago. I don't even want to say I'm a survivor yet. I had breast cancer in 1992. And 27 years later, I have had cancer in the left breast, both caught very early. And I'm a daughter of a mother who died in 1971. And she was probably, if they had the science then, like we have it now, I want to say she probably was very advanced stage breast cancer in 1971, when they were just on the beginnings of tamoxifen that was just being approved through the Food and Drug Administration. I was only 18 at the time. So I'm saying all this to say that even now, and you can't see my face, but I'm 68 years old, and having been diagnosed this past year with breast cancer again, which was a shock to me, there's still a lot that I'm not getting from the doctors. I don't know myself. And my daughter, who now is, she's a nurse, she was really helpful. And she's not a nurse, and she's a neonatal nurse. She does babies, but just listening to her coming with me to my appointments and helping me direct questions that I don't think to ask was very helpful. And as a woman of color, she was, she pointed out some things that another thing I didn't realize that I should be asking or requesting from my care team. So it's extremely important. In circling back and really sitting down and thinking about this, you just don't give everything over to what the doctors say. Right. You have to do some research and be persistent in the questions that you ask. But even at this stage, I still don't know a lot of times, when are you going to check? How do I know that I am cancer free, or am I? Or, when do I come back to see you? Do you do a scan? I still have those questions. As I've gone through chemo and radiation and I'm taking a pill, but okay. So.
Well, I always say the NCCN guidelines, the National Comprehensive Cancer Network, where it'll show you what is best practice, at least. That's the standard of quality care that we can always look at and rely on. But again, just due to, like, for instance, I have a new participant, 71, stage 1 breast cancer, and they went through the standard of care. However, we found that they didn't do the full testing diagnostic workup that they should. They actually just assumed that there was HER2 negativity instead of doing the full panel, just because there was hormone positive. But again, we know that there's triple positive breast cancer. So you can't just assume that it's HER2 negative. And so also, they did do, the lumpectomy and the 5 rounds of radiation, and now they have her on a aromatase inhibitor. However, due to a strong, significant genetic mutation, there actually should be an additional layer of protection and screening and monitoring, just because it increases her likelihood of either developing another cancer or recurring or becoming metastatic later on. And that was
Right.
just not explained to her or or any of that, or
Yeah,
even like to share with her daughters and granddaughters, you know, and
right.
so that they
And
know what their cancer risk is.
yeah, exactly. We've done the genetic testing. There is a mutation. I guess as things go on, maybe there'll be another mutation that they test for and they can find out. But for some reason, excuse me, I wasn't BRCA. I didn't fall into the BRCA1 or BRCA2. My cancer is hormone driven, you know, estrogen driven. Although I'm postmenopausal, it's like, okay, where else is there estrogen? Come on now. But uh, but again, to your point, I've done all the mastectomy, the chemotherapy, the radiation. Okay, so you know, what else
You
do you
know,
want
cancer
to?
adapts. You know, it gets
Yes,
to the point even where it can develop its own estrogen
yeah,
if it can't
right,
pull
exactly.
from the body, even if it is sufficiently suppressed. And that will then create, you know, the cancer tumors expressing new proteins that could be targetable or actionable for treatment.
Right.
And so with you know, cancer is very individual. You know, it's almost like our DNA. You know, so with these tumors, if you crack the code and you understand what drives it, sometimes it very well could be endocrine and hormone related, but other times it could be some other proteins or mutations that are driving the cancer that could be a more targeted treatment instead of just focusing on the subtype. And I could tell you about a participant that we have where she was just treatment after treatment after treatment and just was not responding. And I think it was because the cancer center was so focused on the subtype. And again, as a Black woman, didn't provide the genomic testing and genetic testing. And then when they did, oh, actually, instead of just focusing on these particular treatments that are for this subtype, we can focus on what is actually driving the cancer. And once they did that, now she's stable, even though she's metastatic. And so I think it's just making sure that, and it's so important to have the best treatment early on, because you want that durable response. You want it difficult for that cancer to get a leg up and become resistant to the treatment. So it should be the most targeted and specific for that particular cancer.
Like we all have to be scientists.
Right. But the whole thing is,
And we're not.
you're not alone. That's the whole thing, you know.
No. And hence why Jamil founded her organization.
It was the gap. It was like Swiss cheese
Yeah.
to me. You know, I'm walking around as an advocate and, you know, I'm working with all these, and I'm like, wait a minute, you know, this is something we still need. And, you know, we have tremendous support, definitely more so, I think, than what was the case in the landscape in the past when it comes to metastatic breast cancer. But we still have these gaps. And this is one in particular where, you know, having that wraparound support, having that reinforcement, even during this landscape where you have these kind of gaps that are happening in the care center, because, you know, we're dealing with people. People can be faulty. And so to make sure that you can get the best care possible, having that secondary set of eyes, someone to accompany you, not necessarily to your appointments unless you would like us to, but to have that thought partner, someone who is also experiencing and living with breast cancer themselves or is a breast cancer survivor, you know, they've been through it. So typically when we match patients with coaches, you know, they have a similar lifestyle, similar background, they typically live in the same area, you know, a similar treatment history. So there's a lot of, it's easier to communicate. It's easier to kind of convey the messaging and information. And it's easier to kind of download that background experience and information. And I think that's the reason why the program resonates so well, and why, you know, why some doctors, you know, there's just a communication breakdown where they're not able to explain certain things, or sometimes we come across, you know, some oncology or healthcare professionals that interpret Black women as hostile, you know, and just are not used to communicating with us. And so we're able to bridge that gap and help, how for healthcare professionals, when they are dealing with bias that is a challenge for them, how to communicate better, how to cultivate that relationship with their patient. So that way that bias is not getting in the way, because a lot of times those assumptions will just make them check out. They're not as engaged. They're not as making sure that the patient is understanding everything that's going on. And we can kind of bridge that gap as well.
I don't know if this is a question, but it's more so a statement. For me, right in the beginning, hearing the news, which is so devastating and puts you in such a different headspace.
Yeah.
I wished, and I thank God for Unite for Her, and I would not have known about Unite for Her if it hadn't have been for my church that has a cancer care ministry. But when I had my meeting with the doctors, who I think have been very good, I've asked a lot of questions. Not sure if I always ask the right questions, but I asked a lot of questions. My concern has always been with my particular hospital, the support services are really nothing. And I've asked them, why aren't they connected with Unite for Her? And I talk about doing the acupuncture and this and that. And there's really nothing. One of the things that I had to fight for was a nurse following my surgery. And even though my insurance paid for it, it was it was a huge fight with the nurse navigator about having a nurse. And turns out I really did need one, because I was so nauseous after the surgery that I had to stay, I stayed an extra day in a hospital. So my whole thing is, if it wasn't for Unite for Her, there would be no services. And I don't know how that impacts on other women. I'm a fighter. So, you gonna do for me,
Right.
Exactly.
Advocate for yourself.
I can advocate for myself.
But every woman is not able to do that.
Right.
But my concern with my particular situation, they don't offer anything for support. And
wow,
it's terrible. For me also, I'm almost at the end of chemo, and I ask a lot of questions because I always look at my blood work, and I have my sister who's was in a hematology lab forever, so she gets it. We look at it. She asks questions when I'll say, well, I don't know what this is. What does this mean? So I do have that, but getting ready to go into the next phase with radiation, I'm hearing a lot of stuff, and I'm not sure what I should be asking. I mean, I've asked about, like, when the chemo was done, so what after I do all this, what does this mean? Right. What am I getting, like I've asked, am I getting scans? How do you know that the chemo worked? How do you know that the radiation worked? What are we doing? So those are the kinds of things that I ask, but I'm not sure if I should be asking more. Right. I asked for genetic testing.
Don't know what you don't know. Right?
Yep.
So
exactly.
I just want to know, what else should I be? Where should I go next? That's my whole.
Well,
Sheila,
it is so
what hospital are you
individual.
being treated at, Sheila?
I'm at Virtua, Penn Virtua.
We have tried to, so I think we're going to be able to get there because Penn, I believe, is now partnering. I have tried to get into Virtua. The patients want this program so much. We pay for everything.
I know.
We pay for everything. How do you say no?
And I asked them.
And Virtua was saying, but we do have services. I'm like, you don't. You don't. A yoga class on a Sunday, 12 o'clock.
I know.
Service, and so I think we're going to be making strides there, Sheila, but I'm so glad you were connected with your church. Can you tell me that church that you were?
Enon Tabernacle.
That's what I thought. I thought she was going to say Enon.
I was going to say Enon because we've been working with them. And that was one of the ways, like Jamil, I was saying, I feel like we're missing our women. And we decided that we were going to hold our wellness days at places of worship, or we were going to try and switch it so that we were getting that trust more of the community.
That's really good.
Yeah.
I think Enon is very progressive in, you know,
They
in
are.
what
So
they
we were
do.
talking to them and then COVID hit. So
Right.
Yeah.
we ended up doing a lot of this virtual setting with Sheila.
Yeah.
You probably did the virtual wellness day, but
Mhm.
that did break down some barriers, which was a really good thing, you know, more than we realized with transportation, just work issues, if there's childcare. So that became very, you know, such a positive opportunity came that way, that at least those gaps were bridged.
That's
But we
amazing.
still are looking towards our church ministries. They're
Mhm.
wonderful. We speak there often. Erin did a nutrition talk.
Oh,
at a church
nice.
Yep, at a church ministry. So I'm really happy to hear that, Sheila.
Yeah. Now, one thing I do have to say, my breast surgeon, because when I saw her for my follow-up, and I was telling her I was involved with Unite for Her, and she said she's trying to encourage them to get involved with Unite for Her. So, and I want to write a letter.
Oh,
And
Sheila,
I
I
want to
didn't
write a
tell
letter
you.
to the hospital. I just don't know who to write it
Sheila,
to
I
and let them know.
Yeah, Sheila, I am telling you, the doctors want it, and I have a roadblock, and I won't say the person's name, but I have a roadblock. And
Wow.
I'm sure I know who it is, but I do want
Mm.
to write a
And
letter.
it's not the doctors. They
I know
want
it's
it.
not.
It
I
is
know.
not the doctors, not the oncologists, not the nurses. It is an
Wow.
administration roadblock, and it's really unfortunate.
Mm.
It is unfortunate, especially when you mention Penn Virtual,
Yeah, I know.
because Penn has so many entities.
Well,
I'm a
now
patient.
I think we'll get there because they
Yeah.
are connected. We have every Penn network. So I'm
Yes.
hoping that we're going to be able to get there and be able to circumvent that roadblock. But no, I'm with you. I'm with you.
Yeah.
You can't wrap your head around it where you're like, we pay for everything. Like we literally ask
Yeah.
for so little from the hospital network. That's why the program works, you know, because
Yeah.
we're not asking them to, you know, take their funds away from treating the cancer. We will treat the women. We will do all the fundraising.
And we need it. You know, I don't know who else is part of Penn Virtua, because I don't see, you know, a lot of the patients, but it's needed because there's definitely a missing link there. So I told the doctor I'm willing to write letters. I will write letters. I will
Sheila, I
campaign.
might bring you in on a Zoom meeting with me.
Okay.
I'm
Not a
serious.
problem.
I may
I'm
bring
here.
you in
Nope.
on a Zoom meeting.
I'll do it. I know I will.
Good.
Because there's nothing like a patient to share their story.
And the thing is,
That's what
and
my
the thing
doctor
about
said.
it, and that the thing about it is, it's unacceptable. Now, I know Penn has taken over, you know, not taken over, but joined with other entities. And I can say that because not only am I a Penn patient, but I work for Penn Medicine. And I had got my treatment at Aberson Cancer Center. And my treatment team was exceptional. You know, the first thing I got was genetic counseling. Now, while everything was exceptional, like Jamil says, there's still some loopholes. Prime example, while everybody broke everything down, I had a nurse navigator. I don't really think I needed one, but I had one. I think I had more nurses than doctors. My tumor was caught early. I found out 3 days before my birthday, which is Halloween, which was last year. And yes, I was surprised like everybody else after 10 years of getting mammograms. I'm like, oh, okay. But my tumor was extremely little, to the fact that they're surprised anybody found it because I have such dense breasts. They're shocked that they found something so tiny. But one of the things that I didn't know, I don't remember her saying it, but when the radiologist first called and told me that I had breast cancer, she just mentioned the ductal carcinoma. She didn't mention triple negative. And for somebody who has been a volunteer for Susan G. Komen for many years, it's been a while since I volunteered, but I've always been an advocate. And I was very familiar with triple negative. So when I happened to read it on my paperwork, so mind you, I talked to the surgeon, everybody kept talking about ductal carcinoma. I don't remember the triple negative part.
Wow.
I think I would have done something different. And I probably still could have, but I was like, oh, wait a minute, triple negative. And then I started sending my message in, wait a minute, triple negative, nobody mentioned, I just heard ductal carcinoma. Nobody mentioned triple negative. And triple negative has such a negative connotation. It tends to come back, you know, it's a very aggressive cancer.
Yeah.
So for me, somebody who's familiar, I'm like, oh, nobody's mentioned it. So that's why I had the best team. I had the best care. I feel like everybody told me what I needed to know. There still was some loopholes.
Yeah.
Another thing that I didn't know about was Unite for Her. And I'm saying to myself, I know about Living Beyond Breast Cancer, Susan G. Komen, Praise for the Cure. Why is it that I don't know about Unite for Her? I mean, there's some other organizations I didn't know either. And being somebody where Penn works with Unite for Her, how I found out is through personal choice.
Wow.
And now I'm fortunate. I have 2 insurances. I have mine and my husband. And I feel like if I didn't add personal choice, I don't know I don't think I would have gotten the information like that. So that's when you say loopholes, those are the loopholes.
Yep.
You know, because I think it's important. While they gave us this booklet, I think I still have it. Ken gives you this booklet that has everything in it, right? They give you this booklet. When you go onto the website, yes, you will see Unite for Her, right? You will see some other things, but I just think it's important to maybe mention those things to patients, regardless of whether or not you think they're fortunate or less fortunate or more fortunate. So, because I feel like I would have maybe done some things differently. And then I heard from a friend of mine who's 25-year survivor. She's been having some issues when she got her mammogram. And one of the things she mentioned is that they want her to think about getting a mastectomy, right? Removing both her breasts. And she's really, really leery about doing it because the surgery is so extensive. One of the things she wanted to do was she wanted to get implants. And she dropped the bomb on me. By this time, I already had my surgery. I went through all of that. And she says she was told that with radiation, you can't get implants once you have radiation. And I was like, oh, you sure about that? She said, I talked to 3 doctors. She got more than one. She met with other doctors to make sure that that was true. And I was like, now, not that I'm putting nothing out there with myself, but let's just say it comes back. And let's say I don't want to get both my breasts removed, right? Or, you know, I'm going to do that and I wanted to do that and then get an implant as opposed to reconstruction. I wouldn't be able to do it because of radiation. When you decide to do that, it could cause infection. That's what she said her doctor said. I said, oh, that would have been something nice to know, I think. Because I think that that's something that maybe I would have taken a different direction. Maybe I just would have decided, you know what? I'm just going to have both my breasts removed. I don't want to worry about it coming back. Maybe I don't want to do the reconstructive surgery. I don't want to have to worry about that in the future. You know, maybe they didn't mention it because my tumor is so small. And of course, all of us want to think, okay, it's not going to come back. You know what I'm saying? You go every year to get your mammograms. You're probably not going to ever need to do that, but you really don't know. Do you know what I'm saying? So,
the statistics show that it's a 30%. I believe it's, 50%. Just me personally, just because of the skewed data.
So I commend you for what you're doing, because this is awesome. Like, Unite for Her and getting my care package and learning all these things from everybody. And I have to say, out of a lot of them, I mean, Unite for Her, I'm seeing you everywhere. I'm telling everybody, even, the pharmacist on my job, I work for Penn Medicine at home. So a lot of our patients in home infusion, we have a lot of cancer patients. So I'm like, oh, I got all this information. I can tell people, you know what I'm saying? Have you heard of this organization? Are you doing this? Like, no, that's not a part of my job, but I can talk to my patients about it because they may not know.
Yeah.
So
you're our best voice. And I do think, sometimes the networks are so big, like it's a lot. And we do miss women. We miss women. And that's where, having Jamil as somebody who advocates, with her nonprofit and her work. Yes. I mean, this is a vital resource that we could be giving that has science and research behind it to actually help women do better during treatment and survivorship. That's just for us, I'm grateful to you, Jamil. I'm so grateful because that's a gap. It's a gap that we still see. and we're right there with the nurses recruiting, and we still can't get to everyone. And that's our goal, you know?
Yeah. And so the same way we have those gaps in just the integrative therapies and that additional support, we have those same gaps in the standard of care. And so, you know, it's just critical with all these different individual situations. What is actually the truth, and what is, you know, can you just simply rely on, you know, the roll of the dice and hoping that you have an oncology team that is looking out and making sure that you're getting the best care and that nothing is missed. But I can tell you that with practically every patient of color that we work with, there is something missed, or there was something where the full scope or the full standard of care wasn't provided. And that's why it's so important for us to grow. And that's why we're partnering with organizations like Unite for Her, not just to share, you know, Unite for Her as a resource, but for people with breast cancer to know and learn about us too, that we can be that support, because everyone is not that assertive, vocal, you know, advocate for themselves or patient. And a lot of times it could be overwhelming and scary, and it's just so much information and processing it all. It's really helpful to have that ongoing support that's not too far away, someone who is a coach and knows what you're going through and is there to help you thought partner and structure and connect you to resources and information so that you can make the best decisions as far as your treatment goes.
I love your coaches and your partnering. Thought partner is so key. How many coaches do you have?
Right now we're at 25.
Oh, it's so good, Jamil, like to be able to, you know, connect somebody that is going to have a very similar, you know, path in their social, their emotional well-being. All of that is so key, right?
Absolutely. And again, it's like, because of the fact that we have these gaps in these internal systems, you know, blocking them from getting the support that they need. A lot of times, you know, if that support is not available within the cancer center, we're able to be that bridge to connect them to support, whether it be in that same area where it's a, you know, governmental entity or agency, or you know, it could be, you know, a national organization that can provide that support as well.
What are the requirements to be a coach? We have Janita is asking.
So we do require that they have at least a high school diploma or GED or the equivalent. Associate's degree or college experience is great too, but they should have at least 1 to 3 years of patient advocacy experience, or working in a healthcare setting or a customer service setting, a background in social work. Any of those areas are fine. If you have experience with breast cancer, that's helpful. We then align and match those coaches and people that have breast cancer. But if you haven't had a breast cancer diagnosis, you could also be helpful as a caregiver coach, because we do provide support to caregivers as well.
Nice. Tell me, Jamil, about the hospitals that you're working with, because you also help bridge those gaps and identify those, you know, gaps and blind spots. You said that you're seeing, you know, that's the positive that I'm seeing, right? Like that's the positive, that people are leaning in, they're lifting their heads up, they're noticing more, they're understanding that they do have a racial bias. Like what are you seeing now? I know you said best intentions and the people are coming through, and it's okay if there's still a blind spot, because you're going to help them. You're going to help them see that spot. Like, you allow them to have a very, to be vulnerable. You allow them to be vulnerable with no judgment, so that you can move forward and move your mission forward, and to get this, you know, this resolved. How is that going with, how many hospitals now are you partnering with?
Currently in this area, we have 3, and then we're now in 15 other states. And so the other ones that are gearing up, we're going into the logistical and gearing up and establishing the agreements. So we have 25 cancer centers additionally in the pipeline for this year. And what's interesting is we find that with all these various areas, it's not really where cancer centers have traditionally looked at when you're thinking about the health literacy of patients, or the outcomes, or having the type of focus groups that we have, where they can understand, okay, this is what the hard data is, but what is the actual patient experience? You know, the staff is thinking that this is what's happening, but as far as the actual experience the patient, what is that? And so we're able to kind of reconcile and showcase those blind spots. And one that we found, really great cancer center, really focused on equity and disparities. But come to find out, we did have some oncologists that just had the autonomy to have that bias and make assumptions about Black women. And so would not connect them with like either clinical trials or palliative care or all types of other resources just because of assumptions that this oncologist had. And then also there was the structural issue where if they're, say if a staff member identified that there was bias and that they were treating these Black women differently, what could they do about it? So the oncologist had so much power where they could penalize the patient if they reported it, and could penalize the staff member or nurse practitioner or social worker that could bring it to their attention. So we had to think about how can we create a safe environment where there isn't that penalty that happens. And so again, just a loophole, blind spot, but causing so much damage when you think about this particular, these particular oncologists that are able to unequivocally with autonomy cause harm to patients just because of the color of their skin and this person harboring bias and it's impacting their decisions. But because of these structures and not having that visibility, they're able to do it.
Well, Jamil, we have a lot of hospital relationships. I'm happy to make, connections if you need any.
Awesome.
I feel like you're well on your way. You probably do not need us, but if you do,
Absolutely.
there's definitely more and more, hospital networks that are putting efforts into this. And I'm hearing about leaders in this field, some on our advisory committee for our women of color. So I'd be happy to share that.
Awesome. Thank you so much. I appreciate it.
Yeah.
How long have you been doing this, Jamil?
We just launched in October of 2020.
Wow.
Wow.
Yep.
You were born to do this.
Yeah.
Wow. Because you talk like you've been doing it a long time.
I know, it's weird.
What did you do prior to this? Like, do you do this full time?
Yep. But I still work also as the Chief Financial Officer of Education Works.
Oh,
okay. So you have 2 full-time jobs?
Yes. Wow.
But I did not know that Chrysalis Initiative was going to grow this quickly,
We
Wow.
never do as founders of organizations. That's
Right.
why we work 80 hours a week.
It's your gift.
Yes.
Well, I just look at it like, okay, well, I developed a program for myself to make sure that I was good, right?
Mhm.
And then I developed a curriculum for cancer centers to figure out, okay, how can you make sure that you're meeting the needs of Black people with breast cancer? And then, I said, okay, well, I'm going to share this. And then now that we're sharing it, it's just, blowing up like crazy. And I mean, it's really impactful, and it's not lightning in a bottle. It's not anything new or the latest treatment or anything like. It's literally just ensuring that these patients get standard of care.
Yeah.
Mm-hmm.
And that all the boxes are checked.
Mhm.
Yeah.
And all the I's are dotted and T's are crossed. Like, that's it.
Mm-hmm.
It's good. Yep. Do we have any other questions for Jamil?
Jamil, this is Karen again. So if I were to refer someone to your organization for assistance, you had given me one of your cards with an 800 number on it. Is that the same number?
Yeah.
That I would give to someone?
Go to the website.
Yep.
Okay.
Yep. And I think, Naomi, you had a question?
Mm-hmm.
She's muted.
Can you hear me now?
Yes.
Got it.
Okay. I have ovarian cancer, and thinking about this topic, which I'm ashamed to admit, I never thought about disparities in outcome. I'm assuming that if the disparities in outcome are there for breast cancer, they are very much there for all types of cancers.
Yeah.
And only ovarian cancer, which is basically a chronic condition because it's always found so late. I would like to take this to my hospital I'm if there's any way I can pick your brain on some of the things you've done, I'd like to make sure. I don't even know how to go about doing this, but I'd like to find out whether a white girl like me can do anything to help the women who are in my boat. It's a terrible boat to be in, and it's a boat that you can really never get out of. And the thought that anyone would have a less favorable chance of making it and surviving and living a long life, even with cancer, is really devastating to me. And if there's anything I can do, I've stayed afloat because I've pursued many different paths, had many different treatments, and also done a lot of integrative stuff. And I'm at an MD Anderson facility, which has good standard of care, but they don't really have much else in terms of integrative activity. And I'm just wondering if I can talk to you at some point and find out whether there's something that I can do,
Absolutely.
and not be foolish about it, but be helpful, if that's
Absolutely. And what's interesting, the curriculum that we created is very specific to breast cancer, standard of care, and just how to get the racism and bias out of the way to make sure that people with breast cancer, and especially people of color with breast cancer, can just get standard of care. But we've already received feedback to say, this is so great. What about the other cancers? And so that's something that we're looking at now, but it literally is just looking at the standard guidelines and making sure that what are those gaps that are getting in the way. And a lot of times it is simply bias and racism. And so there has to be, just those accountability and visibility in place. At a cancer center, if you have any type of leadership, or if there's a diversity, equity, and inclusion committee, or if there's a community committee, or one that's addressing disparities, that's really the first step, is to make sure that what are the gaps that are getting in the way of these patients getting standard of care, and don't just rely on that same rationale or same status quo answer of, oh, it's social economic and it's social determinants of health. Sometimes that is a barrier, but a lot of times, since we're dealing with people, the biggest contributing factor in all of these cancers and all of these issues with public health and these disparities is due to racism and bias in the care setting.
And I wonder if part of it isn't that, as a cancer patient, if you're not medically educated, you don't know what questions to ask. A couple of you said that. What do I do now?
Mm-hmm.
And I think having somebody who can help you know what to ask and what to do can be helpful outside of the medical arena.
Yes, very powerful. Because unfortunately, when you think about the same way that there's racism in education, and the same way there's racism in law enforcement, a Black person being vulnerable, seeking care, is kind of rolling the dice. And so unfortunately, we can't just rely on this person having our best interests in heart and going to provide us with that quality of care, because a lot of times we're not even registering that we're a human being, or that we deserve that type of attention and care. And so if it isn't registering to you my humanity, then it's not going to be all hands on deck, and there are going to be gaps missed, and you're not going to make sure that I get the care that I need in order to survive and live. And so unfortunately, it's just not something that we can rely on just in our day-to-day being a Black person in society, receiving care. It's helpful to understand what information that you don't have. And so that's the reason why the Chrysalis Initiative is so empowering for patients, because we're taking off the blind spots in both areas, making sure that the patient is reinforced, and then having that accountability on the cancer center side as well.
Thank you, Jamil. That was a great session.
It was really good. You're going to be getting phone calls. I'm going to be picking your brain too.
All right.
Well, there's 25 of her now, so that's the good thing, is that there's
and we're gearing up for more because of these new hospitals in the pipeline. So it's going to be a busy year.
Yeah.
Jamil, we'll make sure we continue to stay connected, and now, you know, that we're national, that, you know, I appreciate you greatly that you could help us, you know, identify women that we might be
Yes.
missing, just like,
Mhm.
you know, we're able to identify Sheila's church. Like, we look for so many different avenues
Yeah.
because
Mhm.
it's not one magic bullet all the time, you know.
Right.
People might have the best intentions, but it's just not
Yeah,
happening. Yeah.
exactly.
Yeah.
Well, thank you so
Jamil,
much,
it's
Sue.
good. Oh,
Glad
you're
we're in this
so welcome.
together.
Oh, me too. Me too. I'm glad you're in our corner, and be well, and just congratulations. You're a force,
you.
and we are honored to have you tonight.
Thank you so much.
All right.
Thank
Thank you,
you.
ladies, for joining. You have
Thank
a
you.
good
Thank
everyone.
you, Sue.
Great.
Thank you,
Thank
ladies.
Thank you. It was
Jamil.
Bye-bye.
a
Thank
good
you.
session.
Have a good
Thank you,
night.
Jamil.
Great.
Sheila, let's connect, you and I.
Yes.
I'll send you an email.
Yes, and Jamil, I would like to talk with you too.
All right.
Uh,
I need a coach.
you hit a
Hey.
hot button with me, Sheila. You hit a hot button.
Yeah, you hit a hot button. I can't wait to hear the end result.
Oh, jeez. All right. Thank you, ladies. Have a beautiful
All right.
night.
Good night,
All right, bye-bye.
everyone.
Hope you make your
Night.
dinner reservation.
Oh, yeah. I'll be all right. 8:30.
Bye-bye.
Jamil, that was great. Thank you.